Hi, everyone. Thanks for joining us for our last and final session of Navigating the Future, Fiduciary Obligations with Health and Welfare Plans. I'm going to start with the administrative things and get that out of the way. If you would like to ask a question today, look to the upper right-hand corner of your screen, and then you can type in your question. We'll probably wait to the end to get to questions since we have a fair amount of topics today, but we will try to get to as many questions as we can. A common question we often get is whether you'll get a copy of the slides, and the answer is yes, and you'll also get a recording of today's presentation, and that will come in about 2 business days from today's presentation. So who is it that's talking today? So I'm on the left, Michael Durnwald. I'm an attorney in our Cleveland office and a member of our employee benefits and executive compensation practice.
And I'm Beth Mandel. I'm a partner in our employee benefits practice group in our Cincinnati office. And we are looking forward to helping you with all of these hot topics today.
So let's look at the agenda. So first, and we've sort of done this in all the previous webinars, we need to recap fiduciary duties. And the reason for that is sort of you want to get these into your memory. So that's sort of why we repeat them at the top of every presentation. But as Beth said, we picked some hot topics, and the reason they're hot is because they might get you in hot water. Sort of the common theme in these 4 topics we selected is that they're sort of at a heightened litigation and or enforcement risk. So that's how we determined what to talk about today. So let's recap the fiduciary duties. So first off, loyalty. To who do you have to be loyal when you're acting as a fiduciary? And the answer is the participants and the beneficiaries. You are not to be acting in the interest of the company when you have your fiduciary hat on. Second, we call it the exclusive benefit rule. That's sort of the question you ask, like, what is my purpose as a fiduciary? And it's 2 things. The main one, and sort of why they call it exclusive benefit, is that you're supposed to be focused on providing benefits to the plan participants and the beneficiaries. But the second thing that you're also allowed to do is use plan assets or benefits for administrative expenses. But note the key word reasonable. They have to be reasonable expenses, no blank checks. So that's something you need to think of. The third, and probably one of the duties that's most implicated in today's presentation, is prudence. Now, what you see on the slide is sort of the legalistic definition, which can be a bit nebulous when you're reading it, but I'll point out some of the key words. Notice that there it says care, skill, diligence. The point here is that as a fiduciary, you need to be actively involved, not just sort of passively presuming everything's going according to plan. You need to be an informed fiduciary, and you need to be analyzing data and information when you make your decisions. And you need to be deliberative in sort of your decisions. So not just sort of off the cuff details, it's sort of after you analyze the information and data you have, making a decision, and also knowing what you don't know. Sometimes you'll have to engage experts that have knowledge you don't know to help advise you on your decisions. And then the last duty is adhering to the plan document. That's why we have plan documents. They spell out the design of the plan, and then you as a fiduciary are supposed to administer it according to that plan.
And as we'll see today, an important part of this requirement is the duty to follow the terms of the plan document to the extent consistent with ERISA. And so, unfortunately, with respect to a lot of the issues that we'll talk about, there are situations where the plan document might be, sort of trailing where the current state of the law is. And so there could be situations where a plan fiduciary has a duty to actually deviate from the terms of the plan document if the plan document would not be in compliance with ERISA or potentially other applicable law.
And so my last point on this slide is, if there's one thing you remember for this whole webinar series, it should be what your duties are, because those will serve as your guide stone in making all of your decisions. And then if you need expertise, we're here for you, and we can be sort of your North Star as well. So here, if you can remember 2 things from our webinar series, this would be the second one: process, process, process. So that goes towards that duty of prudence and what I was talking about before. It's you need to be deliberative, you need to be analyzing and stuff like that. So most of the fiduciary decisions you have to make are not going to be black and white decisions. It's going to be a sea of gray. And it's if you can demonstrate that you engaged in a process to reach your decision, it doesn't necessarily, that can potentially be fine, and you show that you reached that decision prudently by the process. And then sort of besides the process, it's documenting the process. That's key, because if you can have contemporaneous documentation, such as minutes of your fiduciary committee meeting, that helps provide evidence of your process, and that's something you want in case you're ever sort of in litigation.
All right, and so moving on to our first hot topic, Mental Health Parity and Addiction Equity Act. I will tell you all that, Michael said hot topic because they can get you into hot water. And I also say hot topic because these are the issues that keep me up at night. In fact, last night I had a legitimate nightmare about a request for mental health parity analysis, which we will talk about more during this segment. If you work with either of us regularly, you probably have heard us talk a ton about mental health parity. You might be sick of us talking about that. Why are we again bringing it up today? Because there are fiduciary compliance concerns specifically related to mental health parity, or as we call it, MAPIA. So plan fiduciaries have an obligation to ensure that their plans are compliant with MAPIA. MAPIA is built into ERISA. And so if we think back to those core fiduciary duties, there's the duty to follow the terms of the plan, except to the extent that it would not be compliant with ERISA. And so you've got a duty as a plan fiduciary to make sure that your plans are in step with MAPIA. And a lot of the lawsuits that we're seeing involving MAPIA compliance typically include claims related to fiduciary violations, claims that fiduciaries violated the duty of loyalty and prudence and the duty to administer plans in accordance with ERISA. Plan fiduciaries also have a duty to disclose certain analyses to regulators and to plan participants upon request. We'll go through what those analyses are, but as a fiduciary, you want to be ready to, be able to provide that documentation if needed. So just quickly going through some of the legislative history related to MAPIA. I don't want to get too much in the weeds here, but what we want to basically demonstrate is that mental health parity is not new. It has been around for a long time. The enforcement focus that we are seeing in today's environment is relatively new, basically has increased over the last 4 to 5 years. However, mental health parity requirements themselves are not new. So it began sort of in 1996 with the Mental Health Parity Act. That further evolved in 2008 to include concepts related to addiction equity. And then we end up in 2016 with the 21st Century Cures Act, which required additional guidance from the DOL, including the creation of a compliance program document. There is a self-compliance document that is available on the DOL's website that is pretty good to use if you want to just get an idea of where your plan might stand with respect to mental health parity. And then with respect to the Consolidated Appropriations Act in 2021, that's what really ramped everything up. So that act actually requires plans to prepare written analyses of the non-quantitative treatment limitations that are applied under the plan. And this goes back to that reporting requirement that I discussed under the fiduciary duties related to MAPIA. Plan fiduciaries have a duty to provide those reports if requested by the DOL, and to provide those analyses if requested by a plan participant. And we have seen an increase in plan participant requests, mainly because the DOL is focusing on advertising and making sure that plan participants know that they have a right to request these analyses. And there actually is a form that the DOL put out to aid participants in making these requests. Additionally, the Consolidated Appropriations Act, or CAA, requires annual reporting by the DOL to Congress. And we've been able to glean certain information from that reporting about what the current state of the DOL's enforcement actions are, what sort of violations they are focused on, what they're seeing as widespread in the industry, et cetera. So I'm going to actually flip forward just a couple slides and talk about what are non-quantitative treatment limitations. And under MAPIA, we sort of divide things into two buckets. So we've got quantitative treatment limitations, which are things like visit limits. So you can, have private duty nursing subject to a coverage limit of, 50 sessions per year or something to that effect. Other quantitative treatment limitations would be basically your co-pays, co-insurance, deductible, etc. Basically anything with a numerical limitation, so dollar limits, visit limits, etc. Everything else, so anything that could operate as a limit under the plan that is not expressed as a numerical limitation is considered a non-quantitative treatment limitation. So that would include things like prior authorization and pre-certification requirements, medical necessity requirements, conditioning benefits on completion of a course of treatment, sometimes also, fail first or step therapy protocols. So lots of different things can be non-quantitative treatment limitations. Your general exclusions under the plan are a non-quantitative treatment limitation. Formulary designs are a non-quantitative treatment limitation. And part of the challenge in conducting these analyses and going through all of this is that it's sometimes not clear to the employer plan fiduciaries what non-quantitative treatment limitations actually are being applied under their plan. Some of the limitations are expressly addressed in the comprehensive benefit booklets that you receive from your third-party TPAs, PBMs, but there are some limitations that those medical and prescription drug administrators are applying sort of, behind the scenes that we don't have a great view of sight to. And there are some limitations like standards for network design, network admission, et cetera, that, we not only do not have a good line of sight into, but generally can't get access to because we can't get access to things like network agreements. And so it's important when thinking about NQTLs to sort of think about, who are all the different players who we need to get information from, and how do we begin to start thinking about identifying what NQTLs are being applied under our plan. So let me go back to, now we'll tell you why NQTLs are so important.
Yeah, can you jump to the next slide?
Oh, yeah.
Oh, no, back up, sorry.
Okay.
So this is sort of where we're gonna zoom in now on sort of this written NQTL analyses that you're required to do. And you might wonder, well, what exactly does this mean? A comparative analyses of all of our different NQTLs? And that's an excellent question. And the answer is not really sure, because it's not defined in the statute. But what we do have is we do have some guidance, and I won't read it all to you, but basically the 3 US agencies that are in charge of enforcement for this requirement have issued some FAQs. And what's clear from them is like some of the terminology they use is they expect a, quote, robust discussion, end quote. And then they also sort of give a list of different elements that they expect you to include. They want you to identify, like if you're using an NQTL, they want you to identify every single benefit that that NQTL applies to. They want you to discuss, these are their words, factors, standards, processes, strategies. So they're really looking for a lot of detail, and that's sort of their expectation. And another one is if you use experts, and you probably do because, as just a benefits department, you're not an expert, so you rely on experts sort of with clinical expertise to create your NQTLs. You have to describe the qualifications of these experts, and you need to discuss to what extent did you listen to those experts. So, the key takeaway is there's a lot of information the DOL is expecting on these. And then, oh, did you say?
And I was just going to jump in and say, similar to the basic fiduciary functions, the DOL is really concerned with process and procedure here. So, it's not that you have to be applying a non-quantitative treatment limitation in exactly the same way with respect to medical and surgical benefits as you do to mental health and substance use disorder benefits. But if you do have a unique NQTL that applies to mental health and substance use disorder benefits, or if you're applying an NQTL like a certain medical management standard in a manner differently with respect to mental health and substance use disorder benefits than you are with medical surgical benefits, you have to explain why you're doing it differently. What did you consider in deciding that you were going to apply it differently? What experts did you rely on? What experts didn't you rely on? What sources did you rely on, etc.? Did you, perhaps apply a stricter analytical process in developing the NQTL for mental health substance use disorder purposes than you did for medical surgical purposes? Those are the kind of things that the DOL and other regulatory agencies with enforcement authority are looking at.
And then, can you go back?
Oh, yeah.
And so you see that date, February 10th, 2021. The reason I've emphasized that on this slide is that the agencies put out proposed regs last summer, which we'll go into a little more detail in a few slides here. But in sort of that regulation, in the preamble to the regulation, the agencies over and over again, to the point where I'm reading them and starting to roll my eyes, stressed that, hey, this requirement was in effect since 2021. There's no excuse that if we come to you and say, give us your NQTL analysis, that you say, oh, we don't have it. So that's something that right now, this minute, if somebody asks you, whether it be the DOL or a participant, for an NQTL analysis, you're expected to have that. And then if you go to the next slide, this is sort of the timeline. So the timeline here is what was set forth in the statute. Basically, you start on the left, the DOL requests information, and then you as the planner are supposed to provide the analyses. The thing to point out, again, in these proposed regulations, they're not final, so they're not in effect yet, but they only give you a 10 business day turnaround upon request to get it back to them. And that again goes back to their stance that this requirement's been in effect for quite a while, so you better have them.
And based on what we've heard about requests that have been made already, so under the current guidance, this 10-day turnaround is already essentially being implemented by the DOL. So if they make a request now, there's going to be a very quick turnaround time to get the response to them.
Yes, great. And then so once you provide your analyses, then the DOL is supposed to review it. And if they find that they feel they're insufficient, and we'll talk about a little later sort of their stance and their sort of statistics on that, you would then have 45 days to try and fix it. And then it's sort of this last bullet on the timeline that's the real nasty thing. If even after the DOL gives you a chance to try and fix it, they say you're still not compliant, the plan is legally required to tell everybody enrolled in your plan that the plan has been determined not to be compliant with the mental health parity rules. And the DOL is going to report you to the state, and the DOL can name and shame you in its annual report to Congress. So this last bullet on the timeline is definitely a spot you do not want to be in.
It's basically just throwing up red flags for plaintiffs' attorneys.
That's, yes, good point there. All right, so now I'm not going to go into details on this slide, but what I like about it is the optics. If you see like, whoa, the text font sort of got a lot smaller, there's a lot of content on this slide, and everything that's listed here is stuff that the DOL put in the report to Congress of the deficiencies they're seeing when they do review plans and QTL analyses. And I will point out, if you look under the 2023 report, that first bullet says deficiencies from 2022. So basically in 2023, every single bullet on this list are things that the DOL is not finding sufficient in your analyses. So the takeaway on that is they're probably not sufficient. And so as I mentioned, and promised we'd get to is in the summer, the agencies released proposed regulations. They came out in July, but were published sort of August 3rd. There have been a lot of comments submitted, 9,500, more than 9,500. And there's been a lot of criticisms of the regs, which I sort of, having read them, understand where those criticisms come from, because I think the takeaway when you read them is what the government is asking a plan to do, the plan is not in a position to be able to do. And it comes back to clinical expertise. To really do what the DLO wants, you need clinical expertise. And sort of if you go to that penultimate bullet where it says increased emphasis on applied analysis, you might have already thought the requirements for your written NQTL analyses was pretty extensive, but the takeaway from reading the regs is the agencies feel that's not even enough information and they want more, drill down into more and more detail. They don't seem to be satisfied with anything they're receiving.
I will say, just to play devil's advocate and defend the DOL a little bit, with this round of proposed regulations, we at least got some guidance on how they would expect plans to do the applied analysis, whereas current regulations expect applied analysis, but don't provide a lot of guidance on what exact type of analysis they're looking for, how to do that analysis. New regs would provide some guidelines on that, and that would be welcome.
Yeah, and then I'll mention on that last slide that they sort of introduced a new test. I won't sort of talk about that, but I will point out that when these regs came out, Beth and one of our other colleagues did do a webinar on it that sort of got into more of the details about these proposed regs. If that's something that you're interested in, feel free to contact us and we can get you the recording in the slide.
If anybody's having trouble sleeping at night, I don't recommend listening to that, although it might put you to sleep. But you might have nightmares.
Yes. And so in addition to those requirements from the regs on the last slide, this is a new one. And it seems to maybe be an approach that the regulators are starting to kind of look at more and more. If you think about last year, you had to make gag clause attestations. So I'll be curious to see as more and more laws and regulations come out, if this is sort of a requirement that carries forward. But here, so when it comes to NQTL analyses, at least one of your named fiduciaries is required to review that comparative analysis report, determine that it is compliant with the requirement to have a written NQTL analysis, and then actually certify it in writing, which would go into sort of your overall comparative analysis document that you would report to the DOL. And to give you some context on this, in the regulations, the agencies basically explained that by requiring the certification, it'll sort of force the fiduciaries to really engage with the written analyses and make sure that they are actually reviewing it and not just sort of getting it from their TPA and being like, okay, we got it.
All right, so key takeaways and action items. So as Michael indicated, the DOL has continued to find that the NQTL analyses that were submitted to the DOL are not sufficient. What we know is that the standard NQTL analysis that plans are getting from their service providers are not likely to be sufficient. At this point, most service providers, so your third-party medical benefit administrators, your PBMs, to the extent that they are willing to provide you with any NQTL analyses, they're typically giving you analyses that they have done for their fully insured book of business. And so those NQTLs may or may not apply to your specific plan. And the analyses is not tailored to your specific plan. And the DOL finds that to be insufficient. Additionally, in some cases, the analyses included, the actual analysis included in those analyses from service providers is, lacking certain content that the DOL is expecting to be included, like the as applied analysis, specifically as relates to your particular plan. So how do you go about even starting to deal with mental health parity compliance? First off, even though those analyses that we're getting from TPAs, PBMs are not great, you should still ask your service providers, your TPAs, PBMs, insurers, how they plan to address mental health parity, how they are addressing mental health parity, and whether they can provide updated or initial, if you haven't asked for it yet, NQTL analyses. If the service provider, the direct third-party service provider, will not provide a sufficient NQTL analysis, won't provide a tailored NQTL analysis, then you have to think about what are your fiduciary obligations with respect to next steps to ensure compliance. Do you at this point have to go out and hire an independent vendor to conduct the analysis? And there might be some kind of a question related to this about what is it reasonable for you to do at this time based on the size of your plan, maybe based on how much your plan has deviated from a standard plan design that would be offered or administered by the TPA or PBM that you're working with. The more deviation or customization you have, the more you might want to think about the importance of hiring an independent vendor. If you're not satisfied with the assistance that you're getting from your third-party TPA, PBM, insurer, is this something that you want to think about as a basis to maybe look for a different service provider? Should you be addressing these issues in your in your searches for service providers? And then once you get the NQTL analyses, you have to review the analyses to see if there's been any area of non-compliance that's been potentially identified or flagged, any risk that's been flagged, and think about, do you want to make changes to your plan related to that or recommend changes to the plan related to those risks? And as we've talked about, compliance focuses on both plan design and operation. So we're looking at what's the actual terms of the plan as written, but in operation as well, are you seeing some sort of issue with respect to claims for certain mental health substance use disorder services being denied more frequently than analogous claims on the medical and surgical side? So based on, for example, medical necessity analysis, that could indicate a operational compliance failure. All right, and so now we are going to talk about benefits related to gender dysphoria and gender affirming care. And one of the things that we want to think about in looking at this question is, to what extent is this a settler or plan sponsor issue versus a fiduciary issue? So generally we think of plan design decisions as being settler or plan sponsor functions. So the decision, for example, of whether or not your plan is going to be designed to cover gender affirming care, that could be viewed as a settler decision. However, it also could be viewed as a fiduciary issue, in that the fiduciary has the duty to interpret the terms of the plan and must do so in compliance with ERISA. There are issues that come up in the context of claims processing where the terms of the plan itself may not be, it may not explicitly address how certain types of claims related to gender affirming care are to be analyzed, processed, etc. When we think about some of those, NQTLs that are being applied behind the scenes to the claim in the claims processing context, that might be something that is more of a fiduciary issue. They're interpreting and applying the terms of the plan. And then the DOL has recognized that that as a fiduciary, there is just a general compliance with law obligation. So we have this DOL advisory opinion, for example, that actually dealt with Medicare secondary payer issues. But in that opinion, the DOL expressed the view that plan fiduciaries are responsible for administering their plans to assure compliance with both ERISA and other applicable federal laws, in recognition of the fact that such other laws are not preempted by ERISA. And so similarly, where the terms of a plan are consistent with ERISA, but are not consistent with the requirements of other applicable federal laws or regulations, plan fiduciaries should take appropriate steps to assure that the plan is amended to comply with all applicable legal requirements. So you'll see the DOL's interpretation of that compliance obligation is pretty broad. They essentially are requiring fiduciaries to be aware of, be following, and be responsive to legal requirements, including and beyond ERISA. Okay, so examples of what types of benefits we're talking about when we talk about gender affirming care. So health benefits related to gender dysphoria, that could include things like mental health counseling, hormone therapy, surgical procedures, and there are a variety of different surgical procedures that could be considered to fall under the umbrella of gender affirming care, including things that have historically been thought of as more, sort of cosmetic procedures like calf implants, facial feminization procedures. And so there's a question as to, how to address those types of procedures, whether it's, possible going forward to have blanket exclusions for those kind of procedures, whether such blanket exclusions would violate applicable law, etc. And then there are related disability and leave benefit issues that we're not going to get into in depth here, but it's a good thing to keep in mind that your short-term disability policy, does it have an exclusion for leave related to gender reassignment surgery? Things like that you should be keeping an eye on. Okay, so transgender related benefits, litigation risks related to these gender affirming care issues. So it's increasingly risky to exclude or place caps on medically necessary benefits or treatment that is used to treat gender dysphoria. And we have we have two cases that sort of really moved the needle on this. The first one is Bostock v. Clayton County, a U.S. Supreme Court case. Opinion was issued in 2020. In that case, the U.S. Supreme Court found that Title VII protects employees against discrimination because of their sexual orientation or gender identity. And then in Williams v. Kincaid, a Fourth Circuit opinion that was issued in 2022, that court recognized that gender dysphoria may constitute a disability for ADA purposes. And so that has really moved the needle with respect to a lot of the litigation involving group health plan coverage of gender affirming care. Issues or risks related to coverage not covering gender affirming care arise from Title VII. So we have sex discrimination issues, the ADA with respect to disability discrimination, ACA section 1557, which I'll talk about more in a little bit, which also prohibits sex discrimination, and then mental health parity, which we just talked about, general ERISA compliance with respect to fiduciary duty, and various state anti-discrimination laws. At the same time, it's getting really complicated to deal with gender affirming care issues because we're also seeing an increase in state laws that are banning or criminalizing certain medical procedures. And we've seen some state attempts to basically try to go after or target the practice of covering these procedures or providing benefits for these procedures on the theory that the entity providing benefits is potentially aiding and abetting in criminal conduct. So more litigation examples dealing specifically with gender affirming care. I won't go through all of these, but I'll just say that we've seen an uptick in litigation with respect to plan participants suing their health plans and plan sponsors because the plans did not cover certain types of gender affirming care. And In large part, many of these litigants are successful. Many of the plaintiffs are finding success with respect to these lawsuits. I do want to point out the one lawsuit, CP v. Blue Cross Blue Shield of Illinois. So this is an interesting lawsuit in that it was brought against a third-party administrator, so Blue Cross Blue Shield, an entity that's administering self-insured employer plans on behalf of numerous employers. Section 1557, we just got new regs on Section 1557. It's one of those areas that's hotly contested. Every couple of years, we get new regs on it. When there's an administration change, there seems to be a different interpretation of certain aspects of Section 1557. Various aspects of Section 1557 have been vacated through different litigation over the years. Where we are now, essentially, is that with respect to gender affirming care, Section 1557 is not in most cases going to apply directly to the employer or the employer plan. However, in many cases, it will apply directly to the TPAs administering those plans. And because it applies to the TPAs administering those plans, and because there's some suggestion that TPAs could be held liable, even with respect to self-insured plans, if they administer the plan in a manner that violates Section 1557. So if, for example, they administer an exclusion of coverage for gender affirming care, and that is found to violate Section 1557, then the TPA could be held liable. It could mean that there is a remedy order that requires reprocessing of the claims, which the employer ultimately may have to pay for, or the employer plan. And it also could mean, based on the terms of your contract with the TPA, that you are required to indemnify the TPA for any losses that they have incurred as a result of administering the plan in violation of Section 1557. So all of this basically may indirectly fall back on the employer. And because of this, we may see an increased push from TPAs, PBMs to, cover certain types of gender affirming care that maybe the plan had previously decided to exclude. It's also going to be important to make sure that you're understanding, when dealing with the TPAs, what are the options that you have with respect to making these coverage decisions. How is this coverage going to be administered, and what sort of indemnity obligation do you have? All right. So we just talked in depth about MAPIA concerns, but gender dysphoria is recognized as a mental health condition, and as a result, compliance with respect to gender affirming care is also a MAPIA compliance concern. So it's under MAPIA, it's possible to exclude coverage for a specific condition, but if the plan provides any coverage for the condition, any limitation or exclusion that's applied to that condition with respect to mental health or substance use disorder benefits must comply with MAPIA. And then I'm going to skip ahead due to time, and we'll move on to cross-plan offsetting.
All right, so this is a fairly discrete topic, and I think it's best explained via visual. So I'm going to walk us through a hypothetical example. So the basic situation is we have two companies, Acme and Globex. There's no relation between them. They're totally two separate companies, but each of them sponsors a group health plan for their employees. And they want to hire a third-party administrator to be the claim administrator. And both companies, and because they're good fiduciaries engaged in, an RFP process, we're very prudent, but they both hired Claims Co. to serve as their third-party claims administrator. So let's see that sort of in a visual perspective. So this is sort of the situation I just explained. So on the left, you have your two separate companies, Acme and Globex, and then they each sponsor a health plan. And then they have Claims Co., which is managing the payment process for the claims. And so you see money flowing from Globex Health Plan and Acme's Health Plan to health providers. So that's, hospitals, doctors, counselors, whatever would be covered under the plan. And Claims Co. is sort of in charge of moving that money from the plans to the health providers. All right, so then now let's look at sort of the actions that give rise to when you would need to do a cross-plan offset. So in this top row, we have an Acme plan participant goes to St. Somewhere Hospital and they receive a health service. Then if you look on the right, St. Somewhere wants to get paid, so it submits a claim for $10,000. That was the value of the services it provided to the Acme participant, and it submits that claim to Claims Co., and Claims Co. is supposed to process it. So then we move to the bottom row. Claims Co. takes money from the Acme Health Plan and then pays the bill to St. Somewhere. But what you'll notice here is Claims Co. made a mistake. Instead of paying $10,000, they took $15,000 from the Acme Health Plan and gave it to St. Somewhere. So it's this overpayment, that's sort of the triggering event that causes a cross-plan offset. So now what we're going to see on the next slide is how Claims Co. fixes that mistake. So now on the Globex side, we have Globex plan participant. They also go to St. Somewhere Hospital and they receive some services. The services this time are worth $12,000. St. Somewhere submits the claim to Claims Co. To process under the Globex health plan. So because St. Somewhere received $5,000 extra from the last slide as an overpayment, what Claims Co. is going to do is they're going to underpay them for this next claim. So instead of giving them $12,000, they're only going to give them $7,000. So that's a $5,000 underpayment. So that matches with the $5,000 overpayment. So it sort of equals out. Now, Acme Health Plan's still sort of at a disadvantage because they've overpaid by $5,000. So the second part of the cross-plan offsetting is Claims Co. is going to take $5,000 from the Globex Health Plan and give it to the Acme Health Plan. And so as we'll see on the next slide, if you look at the map across sort of the different players, everything makes mathematical and logical sense. So if you start on the left, St. S, which is St. Somewhere, the locals call it St. S, you'll look that sort of it billed a total of $22,000 and it paid a total of $22,000. It's in between that you see maybe the amounts didn't quite match, but as a net result, they're fine. And on the Acme Health Plan side, here in the middle, they sort of owe $10,000 and they ended up paying $10,000. It just turns out that they overpaid $15,000 and then got it recouped by $5,000, but the net result is zero. And on the Globex Health Plan side, it was supposed to pay $12,000 and it does pay $12,000. It just doesn't pay $12,000 to St. Somewhere. It splits it up and pays $7,000 to St. Somewhere and $5,000 to the Acme Plan. So, from a logic, mathematic perspective, we're sitting here, we're like, okay, that all makes sense. Mistakes happen. It seems like a simple fix. It's administratively easy. But then it begs the question of, is it fiduciarily sound? And fiduciarily is actually a word I verified. But if we go to the next slide, there are some concerns that maybe it would be a breach of duties to allow your TPA to engage in cross-plan offsetting. So on the left here, the one concern is that perhaps allowing cross-plan offsetting is not in your plan document and not consistent with your plan document. And so, this is a pretty interesting quote from this case in the 8th Circuit, where the judge said nothing in the plan documents even comes close to authorizing cross-plan offsetting. So the takeaway from that case is, at least in this court's mind, that if you're going to be engaging in cross-plan offsetting, the plan document needs to say that that is permissible. And that leads sort of to what the other concern is more sort of from the out-of-network claims. From in-network claims, it's fairly simple to see that everything sort of matches up and all that because the TPA's got contracts with provider networks. and it's sort of very clear who owes what. It's the out-of-network claims that seem to be the most risky. And the DOL has taken the stance that to engage in cross-plan offsetting for out-of-network claims, that would violate the exclusive benefit rule. And you might be wondering, like, well, what's the problem? And the problem is when you're dealing with out-of-network claims, providers can balance bill your participants, and that is where they get harmed. So if we go, can you go back to the diagram?
Yeah.
The next one more, yeah. So here in this example, Globex, as you see, only paid $7,000 to St. Somewhere. So even though at the end of the day, St. Somewhere sort of it's evened out, they could balance that participant that incurred that $12,000 claim for $5,000. Now, if Claims Co. sort of knew about it, maybe they could sort of run interference and explain to St. Somewhere that, hey, you know, you got the same amount of money, you're net fine. You know, they don't really owe that $5,000. The problem is the Claims Co. is not probably going to have a line of sight into that balance billing. And so, yes, if your plan participant gets balance billed for $5,000, they're probably going to come to you and complain, and maybe you get it sorted out. But if it's a small amount, like $20, maybe the participant doesn't really know they don't owe that $20, and they might pay it. And in the DOL's mind, that fact that they paid that $20, that's a harm. And so that's where they raise the condition of fiduciary duty. All right, so that's sort of what the issue is about this practice. So what do we do about it? The first step would be to understand your current state and what's going on. This goes back to prudence. You know, you're supposed to be involved and have knowledge and actively engaged. So first, what does your plan document say? My guess is it doesn't cover cross-plan offsetting, but maybe it does, maybe it prohibits it, maybe it specifically allows it, maybe it's silent. My guess is it's probably silent. But then you also want to look at your services agreement with the TPA. Does that address cross-plan offsetting? If it does, is it prohibited or is it permitted? And then even if your service agreement allows for cross-plan offsetting, you want to know, like, well, is the TPA actually doing cross-plan offsetting? Because if they're not, then you don't really have a concern. And then lastly, if you do know cross-plans offsetting, you want to distinguish, is it just in-network or out-of-network? Because again, it's the out-of-network cross-plan offsetting that really raises the concerns. So once you sort of figure out your current state and situation of how you're handling cross-plan offsetting, the first thing would be, if you are engaged in that practice, you want to amend your plan document to authorize the cross-plan offsetting if it's not already authorized. That sort of negates that court cases sort of opinion that you're breaching your fiduciary duty to adhere to plan documents. So you at least sort of negate that concern. The next question, though, is sort of that harder issue of the exclusive benefit rule and the DOL stance on that for the out-of-network benefits. So what you can do in your service agreement, so if you're negotiating a new service agreement, maybe you just try and prohibit cross-plan offsetting. You know, because if you're not engaged in the practice, then you don't have the fiduciary concern. Or, you know, if the TPA is not willing to do that, try and limit it to in-network only, because it seems that, you know, the DOL is a little more okay with that. It's really sort of the out-of-network that's the problem. Now, if you do manage to get a prohibition on the practice, here's some other tips that you see here in the box. You want to make sure, though, in your service agreement that you have given your TPA authority to recover overpayments. It might be relying on cross-plan offsetting as a way to do that. And so if you take that away, you want to make sure that they're going to still have some means that you've authorized them to collect overpayments, because as fiduciaries, you don't want to be making overpayments and just sort of ignoring it and paying more assets out of the plan than what is actually owed. And the other thing is, if you can't get cross-plan offsetting off the table or in the agreement, try and get indemnification for any liability that would arise due to the cross-plan offsetting. Since it's the TPA that wants to use this method and you didn't want them to do so, then say, all right, if you want to use it, you won't let us prohibit it, then you're going to indemnify us if it sort of comes back to bite us.
And I'll just add that, you know, from experience, so we want to go back to the principles that we talked about at the beginning with respect to fiduciary duty, which again, process, document the process. And so, you know, the fiduciary has to act in a prudent manner. With respect to things like cross-plan offsetting, the DOL certainly has a view that they have expressed, and informally they have expressed that they believe cross-plan offsetting violates ERISA, whether done out of network or in network. However, we don't necessarily have controlling law on this yet, and plan sponsors in dealing with their TPAs, plan fiduciaries in dealing with their TPAs might determine that based on the options given to them, it would be more prudent to allow something like cross-plan offsetting, particularly if it's limited to in-network only, than to opt out of that practice, because if they opt out, they might be missing out on significant recovery dollars that then result in, you know, increasing the overall price of plan costs and potentially increasing costs for participants. So it's all a matter of just making sure that you are, as a fiduciary, engaging in this deliberative process, documenting that you've engaged in it. And if you know, at the end of the day, when you make a decision, documenting why you've made that decision. How are you going to justify this? And it's the same thing, you know, just going back to the gender affirming care question and whether or not to cover gender affirming care. Plan fiduciaries should know what their plan covers, know how those types of claims are being administered under their plan. If there is, you know, an exclusion under the plan, the fiduciary should consider, you know, is that exclusion potentially justified? Is there something that we can rely on to demonstrate that this has not resulted in a violation of applicable law? Do we have some sort of argument for a religious exemption? You know, is there potentially state law that we're trying to comply with? If we are concerned about state law issues, if we're living in an area where certain types of care is banned, but we have potentially employees who are, if we're headquartered in an area where care is banned, but we have employees who are living in other areas where that care is available, you know, do we decide that, yes, we understand there are risks with respect to state law, but we believe ERISA preempts, and so we're going to continue to provide coverage, but, you know, make sure that our plan states that coverage will not be provided with respect to services that are unlawful in the jurisdiction in which they're provided. So there are many different things that need to be addressed, thought about, et cetera, when engaging in this analysis. And the biggest takeaway that we want you to you know, leave this presentation with is essentially fiduciaries can't just be asleep at the wheel on these issues. You have to kind of know, what are the hot button litigation issues out there? What are my duties with respect to those issues as a plan fiduciary? And how should I be thinking about these issues when I'm administering our plan? And so the final hot button topic that we're going to talk about is HIPAA privacy and security. We could do, you know, several hours on HIPAA privacy and security alone. We've got a few minutes left. I'm just going to quickly go through some of the HIPAA privacy and security concerns and why we think it's a fiduciary issue. So just to level set, what are we talking about when we talk about HIPAA? We're talking about the Health Insurance Portability and Accountability Act of 1996. That covers a broad array of topics. Today, we're specifically focused on privacy and security issues stemming from and arising from that act. There is a privacy objective under HIPAA that imposes national standards to protect medical records and other individually identifiable health information. There are various privacy and security standards that plans are expected to apply in order to protect that information. And there's a breach notification rule that plans are expected to follow in the event that there has been a breach of unsecured protected health information. Now, HIPAA affects healthcare providers, healthcare clearinghouses, and more importantly for today's purposes, health plans. Those are considered covered entities. It also impacts business associates, which are certain types of service providers that provide specific types of services to those covered entities. So if we think about just like our main third-party administrators, pharmacy benefit administrators for group health plans, they would generally be business associates. Employers themselves are not covered entities. However, the group health plans that employers sponsor generally are covered entities. So we have to sort of think about the group health plan as being almost a separate entity in this context. Okay, so impact on group health plans. So HIPAA imposes basic obligations. Just to run through those really quickly, you have to distribute a notice of privacy practices. There are restrictions on use and disclosure of PHI. You have to maintain certain safeguards for protecting PHI. You have to adopt written privacy and security policies and procedures, appoint a HIPAA privacy official and security official. You have to implement workforce training and management, make sure that business associate agreements are in place with all of your business associates, conduct regular security assessments, and comply with those breach response obligations. And why is this a fiduciary concern? Plans have to include certain HIPAA privacy and security provisions in the actual plan document. As a result, fiduciaries have a duty to administer the plan in accordance with those provisions. Again, the duty to act prudently and in the sole interest of plan participants comes into play here, in that there's a duty to manage privacy and security risks arising under the plan. And HIPAA imposes various obligations on covered entity group health plans that in practical terms results in responsibility falling to the plan fiduciary or its delegate. The HIPAA privacy official and HIPAA security official could be viewed as a plan fiduciary. They're typically not a named fiduciary, but they could be a functional fiduciary in that they have discretionary authority or discretionary responsibility with respect to certain aspects of plan administration. For example, they have discretionary authority when they're developing and implementing policies and procedures reasonably designed to take into account the size and type of activities that are undertaken by the plan. They have discretionary authority when they're implementing training. The training has to be necessary and appropriate, again, based on the circumstances. And they have to develop appropriate sanctions policies. So you can see how all of these different requirements and many others that apply under HIPAA involve some level of discretion. And therefore, it's very likely that privacy officials, security officials could be viewed as functioning in a fiduciary capacity.
Yeah, and can you just skip to the enforcement actions? So basically, the slides we're skipping are, our point to you is that HIPAA security enforcement is heating up. The slides we skipped, sort of, you can look at, they're just data from the Health and Human Services that they've issued about sort of that data breaches are becoming an issue. And then here, just a couple handful of recent enforcement actions from the HHS, but the note sort of if on the second bullet for each what the settlement amount was. And so that's sort of the takeaway, is that, you know, if you violate these provisions, it can sort of be a significant amount of liability for the company. And sort of the security issues, but then also, even though privacy has sort of been around for a long time, people still violate that. And then just to put you on notice, HHS sort of in February announced that they're going to do a new enforcement initiative. They're calling it the Risk Analysis Initiative. We don't really know much about it, other than HHS says, you know, every time we investigate, pretty much always people aren't complying with the security rules. So we're going to go after that.
And just to leave you with another thing to worry about, there were new regulations that recently dropped related to HIPAA compliance and reproductive health information. We are still working through the new regulations. We'll be talking to our clients about these and the impact that they will have on your plans. But the takeaway here, I think, is that, you know, we continue to get new developments in this area that plan fiduciaries, again, need to be aware of. For the most part, we think these new regulations are going to impact your business associates more so than they will impact the plan directly, but they will require certain things like updating of privacy notices. And there could be situations where plan sponsor or plan fiduciaries are administering benefits in-house without the assistance of a third-party administrator, like some of these travel benefits that were adopted in response to the Dobbs decision. That could, this could result in heightened administrative burden and fiduciary burden with respect to those types of benefits that in-house fiduciaries are going to have to deal with.
All right, so that brings us to the end. Unfortunately, we are sort of at our hour, so can't get to all the questions. The good news is we were able to work in most of the questions into our discussion. For those of you, if we didn't answer your question, we will try to get back to you offline. And then just a few administrative notes. Remember, in about 2 business days or less, you'll get a copy of this recording and the slides. And if you didn't have questions answered and you didn't submit them, feel free to contact your normal Thompson Hine benefits attorney, or me or Beth or anybody at Thompson Hine. We can figure it out. And lastly, just thank you. We appreciate your attendance to our webinar series. We hope you found it useful. Hopefully not too scary, but I do imagine this picture is perfect for how you're feeling at the end.
Hopefully not. Hopefully we're not feeling like our heads are exploding now, but we are here to help if you do feel like that.
So again, thank you, and we'll be in touch.
Yeah, thanks everyone.